Okay, good afternoon. It is 2:47, and since we are going all the way till the end here at 4 o'clock, and I got a ton of information encapsulated in this PowerPoint slide, we'll just get started right off the bat. So, my name is Scott Sanders. There's the QR code to sign into the talk today. Thank you guys so much for coming out to my breakout session, which is Beyond Traditional OCD, talking a little bit about recognizing and addressing atypical obsessive compulsive presentations in autism and intellectual disabilities. There's a bunch of learning objectives. I put them up there because they're really important, but in the interest of time, there's so much other stuff I want to get to, I'm just going to skip this slide. If you want the slides later, I'm more than happy to share them afterwards. So, all right, now that we're beginning. All right, let's just address the elephant in the room right out the gate. You came to a talk about something that may or may not exist. Atypical OCD is not a formal diagnosis, okay? It is the best way that I have been able to represent this idea to doctors and psychiatrists and families and people. Atypical OCD refers to obsessive compulsive disorder presentations that deviate from classic patterns that are typically seen in neurotypical populations. In individuals with autism spectrum disorder and intellectual disabilities, OCD often manifests in ways that challenge those standard diagnostic criteria. In fact, there's some research back in 2017 in the Journal of Autism and Developmental Disabilities that identifies that OCD symptoms in autism populations frequently manifest through behavioral channels rather than verbally reported obsessions. Makes sense. A social communication disorder where a person may have a tough time expressing certain thoughts, feelings, ideas, concepts, things of that nature, it would make sense that they have a tough time expressing those things. So they referred to them as behavioral OCD phenotypes. And that makes more sense when you think about it in terms of a behavioral expression of what we typically understand. So before we go any further, let me tell you about how all this started. So about 3 years ago, I started getting a couple of cases on my caseload that all seemed to be following a very similar pattern of things that were happening, and it just started occurring to me that maybe something else was going on. Now, to be fair, many, many years ago, as a younger behavior analyst, I was working with a doctor who I trusted and respected very much. And he was a psychiatrist. He had been working with me, and at one psych review, I can remember people were referring to the young men that we were working with autism and the OCD behaviors that they engage in, and the doctor stopped everybody and he said, "Hey, I just want to tell you guys, people with autism don't really have OCD, all right? So I get what you're talking about, but can we just refer to it as OCD-like behavior?" And I thought, oh, people with autism don't have OCD? Well, okay, we'll just go. We'll call it OCD-like behavior from now on, doc, that's fine. And we just kind of went with that assumption, right? And so when I came across this caseload a few years ago, it was a bunch of that. It was a bunch of OCD-like behavior. Every family, every provider agency was reporting the same thing. These behaviors were coming out of nowhere. There was no identifiable environmental trigger to any of these target behaviors. And yet the person was acting on something, and if they could verbalize something about it, they would say, "I have to do this thing." And that was their only explanation. And it started occurring that it felt like something else was going on. And in almost every one of these situations, a similar pattern had occurred as well. The family or provider agency had been working with this individual for a number of years. This person had been stable and been doing their same things their whole life. And then out of nowhere, something changed. Sometimes it was puberty, or sometimes some major life event or a major medication change. Something changed. And so in that event, they would go to their doctor and go to the psychiatrist and say, hey, doc, my loved one, I don't know what's going on, but out of nowhere, they're just kind of getting really upset, and they come over and they start hitting me, or they start hitting themselves. I don't know. It feels really impulsive, and I don't know what's going on. So the doc hears that, and they think, oh, impulsive behavior. Okay, I got something for that. And in almost every case, the person had been prescribed an antipsychotic, and within 6 weeks was showing some symptoms of side effects from the antipsychotics, because that may or may not have been the medication that was necessary, right? And then sometimes 2 to 4 years down the road, somebody like me comes along with this crazy idea about OCD-like behavior, and I'm just having this conversation, and here's what happened. So I had a brand new client. It was the second time I was meeting with him and the mom, and I was observing this phenomenon. Mom kept reporting this thing, no antecedent, behavior was very explosive, felt like he was controlling things that she was doing and everything else. And I said, here's this conversation I had with a doctor years ago about OCD-like behaviors. And we started talking about OCD-like behaviors that her son was engaging in. I left that day having given no formal recommendations, just having thought I had a conversation with Mom. Just so you know, Mom's a little feisty. All right? So I returned the following Monday, and like a good ICPN staff, when we get new staff, I let people go shadow me. I happened to have 2 staff shadowing me that day as we walked through the door, and the mom goes, oh my God, Scott, I could kiss you. And I was like, wow, that's really inappropriate in front of my 2 colleagues. Please explain. And she said, our conversation last week, it really made sense. So immediately when you left, I called my doctor, and I chewed his ass out. I told you she was feisty. I chewed him out. Why did you never think of OCD? This guy sees him for an hour and starts bringing up OCD. And so the doctor made a medication change and suggested an SSRI that one they believed was more specific for OCD. Mom gave it to her son on Friday night. Saturday morning, she reports that her son came downstairs, walked up to her, hugged her, and said, I love you, for the first time in a year. And I was like, yeah, that doesn't work in 12 hours. No. Tell me more about the weekend, Mom. No target behaviors, no physical aggression, no property destruction, able to tolerate a bunch of stuff. I was like, wow, okay, well, that's different. Okay. Immediately upon leaving that house, I turned to my new coworkers and I said, it's not the meds. I don't think it's the meds, all right? Just so you know, meds don't work that fast, all right? Those are meds that take like 6 weeks. So 12 hours is not enough time. I don't think it was the meds. But something's going on, okay? And we got to figure this out. And they both agreed that Mom was feisty, and but that something was different, and there was something to what Mom was saying. Her son had presented differently. Just as kind of a fast forward on that one, a year and a half later, I was sitting in Michigan at a work retreat, and I was sitting there on a Saturday, and I got a notification from that mom on my phone, and it was a picture of her son sitting in a pool. And I was like, oh, cool, all right. I didn't think much of it for about 5 minutes, until I realized that Mom had just sent me a picture of her son sitting in a pool at Disney in Florida. She had edited out everybody else. He was in a large pool at Disney in Florida for the first time. This guy who couldn't go to the store 6 months ago was now sitting in Disney in a pool in Florida. I was like, what is going on? There's something going on to this whole idea. And so it started with one of those cases, and I started having to research it more and figure out this thing. Like, I don't understand this thing. So for today, we're going to talk a little bit about defining this atypical OCD and these presentations that deviate from classic patterns. So let's start with the DSM-5 criteria. So what does it look like just in the DSM-5? The presence of obsessions and compulsions. Obsessions are defined by recurrent and persistent thoughts, urges, or images, Well, even nonverbal individuals can have those things without being able to express them, right? And sometimes they may come out in the form of compulsions, which are defined as repetitive behaviors or mental acts that the individual feels driven to perform in response to an obsession or according to rules that must be applied rigidly. Are sometimes rules formed that don't make logical sense, but yet people have to adhere to them anyways? Sound like something we know? Yes. Behaviors or mental acts are also aimed at preventing or reducing the anxiety or distress or preventing some dreaded event or situation. However, the behaviors are not connected in a realistic way with what they are designed to neutralize or prevent, or are clearly excessive. The other ones, obviously, they become more time-consuming, and the symptoms are not relatable to something else. Obviously, there's other specifiers in there. So if we just look at that criteria, that makes it pretty difficult for nonverbal individuals with intellectual disabilities, and anybody that can't tell you why they're washing their hands 100 times a day, right? Insight assessment requires self-report, making formal categorization impossible in nonverbal individuals who can't express those things. Traditional OCD diagnosis also relies heavily on self-report. The person has to be able to tell the doctor, this is causing me distress. Nonverbal individuals cannot describe those obsessions, which makes it extremely difficult to distinguish OCD compulsions from stereotypies, self-stim behaviors, and other repetitive behaviors that are very common in autism. But the last one is also an important piece of recognition difficulty. Behavioral assessments, and I've run into this time and time again, and as a behavior analyst, I'm also guilty of this in the past. If we do behavioral assessments on OCD-like behavior, we are generally always going to come up with the same function, automatic, always, right? Because if the person is not doing it for attention, right, they're not tearing tags off of other people's clothing for attention if they would be doing it independent in a room by themselves, right? They're not doing it to escape demand. They're not doing it just for the tangible thing, especially if they just tear the tag and drop it and leave it. They're not doing it for a tangible thing. It is an automatically maintained behavior. But here's where we're guilty as behavior analysts. Automatically maintained behavior suggests that it is pleasurable, self-soothing, and reinforcing to the person in some way. If we are putting that it is an automatically maintained behavior and the person's doing the thing and they're in distress, that's not the automatic function that we as behavior analysts typically tend to think about. So if it is causing distress as an automatic function, that may be more suggestive of something else other than an autism-restricted related repetitive behavior. Behavioral indicators may also suggest a level of conviction. Time and time again, especially in the caseload that I had, you would see behavioral interventions that had been in place for sometimes 10 years. We've been doing this behavioral intervention. It's like it just never worked. Complete unmodifiable resistance to this intervention may be because it's internally regulated, has nothing to do with the environment. It may present as more severe treatment persistent symptoms as well, and higher risk behaviors if it involves harm prevention. And oftentimes caregivers, as well as clinicians, can misattribute OCD symptoms to underlying developmental disorder, especially if the autism RRBs, those restrictive repetitive behaviors, look very similar to the OCD that the person is engaging in. It's oftentimes overlooked. And so in my research, I had to put this one just to disprove that doctor, who I will always love and respect that doctor. But the moment I found this out, I said, you were wrong once. People with autism do have OCD, and it's suspected 17 to 37%. That's a pretty wide range. That's a pretty wide range, and much higher than I think people would expect in the typical population of individuals with autism. Other relevant factors: age of onset. Autism, you tend to see those restrictive repetitive behaviors from a very early age. OCD symptoms tend to emerge later in life, especially even on the caseload that I have where a lot of these questions started popping up. Most of the families, most of the providers all said, it was around puberty. It was like puberty, but it was kind of after puberty. It was like 2 years after he started puberty. And it was like, okay, so puberty may not have been just the thing, right? The hormones had already changed and now something else had been occurring. Distress and resistance is also different with atypical OCD than it is in individuals with autism spectrum disorder. Unlike autism-related repetitive behaviors that are often pleasurable or self-soothing, self-stimulatory, OCD compulsions typically cause distress, and the person may show resistance or frustration when prevented from completing them. And this isn't just like the normal amount of resistance or distress where, hey, I know that you really like McDonald's, today we're going to Wendy's. Like, not that type of distress. Like, we're not going to McDonald's and next thing you know, somebody's getting hit until we go to McDonald's, right? That type of difference of distress. One of the other relevant factors is the functional impairment that the OCD may cause and how it interferes with the person's daily functioning in ways that are distinct from autism-related challenges. I have a young man that I'm working with now who we're trying to differentiate and disentangle what is OCD from, what is his autism. One of the most unique things that we're trying to figure out is a fixation that he has on automatic doors. And my suspicion is that he actually has OCD about automatic doors. And here's why. For the most part, this young man uses an AAC device to communicate with others. He goes to a public school. He is in most of his class are with typically developing individuals. I've observed in this class, I'm more overstimulated than this guy gets, all right? So he's doing pretty well, right? But when he goes to the doctor, from the moment he passes through the automatic doors, goes up to the second floor, and is interacting with the doctor, and until he has left that building, and for approximately 10 minutes after he leaves, the only thing he can do is sit there on the AAC device and sit door, 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 door. And when we're talking about this, I said, how long has this been going on? Well, last couple of years. Where does it happen? Only at the doctor, only with automatic doors. And so I said, well, okay, does he seem okay with the interaction with the doctor? And they're like, it's weird. It's like he's sitting there and he looks happy to be talking or interacting with the doctor, but it's like he's distressed while he's saying door over and over and over. And I said, well, I've seen your son sit in class, and he's like, hey, the answer is this. Hi, Scott, how's it going? So if he's in front of another human being whom he wants to interact with and is unable to because he has to do this thing and engage in this compulsion, and it looks a little, is he distressed or is he happy? Mom goes, oh, he's distressed. Okay, it might be something other than just a restricted repetitive behavior. And they said, yeah, more stories about that young man later. The last one here, response to interruption. Autistic stereotypies may stop easily when redirected. OCD compulsions often show persistence, agitation, or escalation when interrupted. The magnitude of distress experienced by the individual being interrupted can often result in physical aggression, property destruction, or self-injurious behavior in order to complete or the ritual or routine. Which brings me to one of my favorite stories of all time of individuals with OCD. And it was fascinating. So I was working with a young man in his teenage years who was transitioning to a group home up near Joliet. And in talking with his residential provider that also happened to be a school, I said, is there anything unique about this young man? And they said, yeah, his OCD. And I was like, oh, what about his OCD? And they were like, well, it gets bad at times. And I was like, how bad? And they were like, well, there was a period of time where he was so obsessed with the movie Toy Story, the DVD of it, that it required a full lockdown of the school and a 5-person escort to take him to and from class. I was like, I'm sorry, explain this to me. What? And they said, yeah. As he was entering the school, they would lock down every door in the school, because if any door was unlocked and he believed Toy Story was behind there, he was going to go through all 5 people to get to it, and everyone else in the way. And I was like, what? Wow. So full lockdown, 5-person escort to and from school. What? And they said, yes, he's gone through doors. He has literally gone through anything, people, multiple adults, and he was a little guy. All just to get the DVD, just to put it into a DVD player. I would say that's distress. I would say that is disproportionate to his developmental age, to anything having to do with what he was experiencing. Some fun stories about that young man later as well. All right, so in terms of how to define atypical OCD, I'm proposing 3 key distinguishing features. The first here is limited verbal expression of obsessions. Many of the individuals with autism or intellectual disabilities who are experiencing an atypical version of OCD may express more behavioral OCD phenotypes. Atypical presentations of obsessions may be more non-verbally expressed through behavioral indicators, distress, the amount of distress a person is experiencing, their facial expression, inability to communicate with others, in the presence of triggering stimuli, increased intensity of physical stereotypy in the presence of particular stimuli, agitation, irritability around these situations, body language, controlling others' behavior. I have a story about that one a little bit later. Utilizing another person in the role of a stimulus with abnormal intensity. Same story. All of these nonverbal expressions of the obsessions, you're not going to be able to hear the person tell you what it is, right? You're going to see it in some form or fashion. It is going to be seen when, and sometimes it'll be a retroactive thing. As I was doing the research for this, I can't help but think about a young man that I worked with years ago when I lived in Tennessee. And he had, I worked with him for 4 years. The only time the guy ever went to the hospital, when I showed up and they said he was already at the hospital, he just destroyed the place, he hurt somebody. I was like, what happened? And they were like, I don't know, it came out of nowhere. Should have been a first sign for me, huh? Now this guy had some unique things. He took little spit wads and he would line them up all over anything, but that was an RRB, and we knew that because if you came up and you did this, he was fine with that, right? But there was other stuff in his room, if you touched it, you got hit, right? And in particular, he had a closet where he was collecting newspapers for the last several years, okay? And so you imagine the stack and how high it had gotten. When that gentleman got back from the hospital, after a whole lot of asking questions and everything else, I said, what was it that upset you before you went? And the only thing he could say was repeating 3 different dates over and over and over and over. And I was like, what about these dates? Finally, after about a half hour of listening to these 3 dates over and over and over, I asked the house manager to go to the closet with me, and we were looking at the newspaper stack that was completely chronological. Guess which 3 numbers were gone? All he had to do was see the stack, and he knew what was gone. That's an obsession. Not knowing where it was, not knowing the answer of who took it, where it was, or anything else. That's the only time he was hospitalized in the 4 years I served him. I can't help but wonder if that gentleman was really suffering with the OCD, and we were perhaps treating something else at the time. Also, in terms of the limited verbal expression, the explanation the person gives may be more simplified or concrete rather than abstract. Maybe the fear of specific textures and, rather than contamination as a concept. A person may verbalize a specific reason for atypical presentation without a logical reason, right? I'm working with a young man right now, and he lines up these little figurines that he makes. And the moment I saw them, I was like, hey, tell me a little bit about these. I'll talk a little bit more about this later. And he's like, these are my papers. And I was like, yeah, that's cool. Those are awesome, man. And he had them all over the coffee table. And Mom goes, yeah, and they used to be all over the wall. And I go, yeah? Why aren't they anymore? And she goes, oh, he eventually took them down. But when they were, we couldn't touch them. And I go, really? What would happen? She said, he would hit us. I mean, really come after us if we even attempted to touch it. I said, oh, okay. And so I said, hey, buddy, what was so upsetting about people touching it? Therefore, display only. That was the rule. That's all I needed to hear. That was pretty concrete, right? Therefore, display only. It's like you read the sign at Toys R Us and took it very seriously. Okay, bud. He's great. I like working with him. He's a lot of fun. So they're difficult to distinguish from autism-related repetitive behaviors without really, really careful observation and analysis. The second distinguishing feature that I'd like to propose here are the atypical compulsion patterns themselves. Rather than those classic rituals like hand washing, checking on things, and things of that nature, in atypical presentations, they may express as unusual ordering of things, arranging that differs from typical autism-related preferences, right? A person who may have a hoarding issue in a very specific location. It has to look very specific or otherwise something will happen, right? Symmetry, order, just right phenomenon beyond the typical autism-related preferences, right? There are some individuals who, and you probably worked with people that want echolalia, right? They'll say a word, Bobby, and they want you to say Bobby, right? the same way back, right? I've come across many individuals that have that type of vocal stereotypy. In situations where it's atypical OCD, the person is asking for that thing, and if you are not able to say it with the exact tone and way that they want, that's when physical aggression or self-injurious behavior occurs, because it's not just right. It has to have that just right feeling before the person's able to move on. One example that I gave up here was Disney stickers on an iPad. I had a referral for this gentleman, and thankfully he had a diagnosis of OCD. But what was really funny was I asked everybody what his OCD was, and nobody could tell me. I was like, oh, okay. So I was at the day program, and I said, hey, is there any day or part of the day at the day program he's perfectly fine? They said, yeah, the last 20 minutes. I said, huh, what's he doing the last 20 minutes? And they said, that's when he gets his Disney sticker. And I was like, oh, well, that's cool. Is it because he gets the sticker? And they're like, yeah, I assume, but he's fine the rest of the day. So I stuck around the rest of the day to see what this phenomenon was. And so Bobby would get the sticker, and he would go off to the corner of the day program, and then for the next 20 minutes, he was putting it on, and then getting it precise, and then it wasn't right, and then he had to take it off, and then he had to put it back on. He was not a happy camper in the corner for the last 20 minutes of the day. He was experiencing distress because he couldn't get that darn sticker, which this whole thing's loaded with 4 years of stickers. He couldn't get it just right because the other ones are fault. Do you see where the last 20 minutes was perfectly fine? Because he was in distress. Nobody understood what was going on. It was pretty fascinating to watch. Tearing tags off of other people's clothing, right? Have lots of people that don't like the sensory sensation of tags on their own clothes. They tear those off, right? But what causes a person to go up to a random stranger, tear the tag off of their clothing, right? Unless there is some thought in that person's head of, I need to go do this thing, right? And here's where I'll make the case of where it could be a little bit different if it's atypical OCD versus some autism-related restricted behavior. With atypical OCD, you will see a pattern of a little bit of anxiety or distress as the person's doing it. So did you ever see that surprised facial expression? Like, oh, I can do the thing, right? And then as the person's engaging in the behavior, they're like, oh, and then after they do the behavior, they have that sense of relief. Oh, it's done, right? Even if they leave it, if they take it, whatever it is. Classic pattern of OCD. Anxiety before, engage in the behavior, relief afterwards. If they're following a similar pattern and it is consistent across their environment, meaning it's going to be completely random and not consistent across their lifespan. Also, the funny thing about OCD, it can come and go in terms of how much a person is fixated on that thing. Grabbing glasses off of the faces of strangers. This is one that I included because I have a young man that does this. I included this because I really find it ironic that both of his parents wear glasses, but no other adults can wear glasses. So imagine how hard it is to take him to Walmart and and every person, he's got to grab your glasses. He's just throwing them. He's not breaking them, but he's throwing them. I recently learned he also doesn't like babies, apparently, and now is acting as if he's going to punch him. And I was like, well, we got to stop this. No babies need to get punched. So that's just not okay. Obsessively following around individuals. We'll talk about that in a little bit. Tearing clothing for anxiety reduction. I've seen that. Also, the tearing stickers off of items, right? We all know that person that probably takes that sticker and just picks at it all day. Then there's other people that they just, it feels good. It's a sensory thing to pull that sticker off. Then there's that person that will go through 10 people to get that sticker that they happen to see in the room next door, right? If you've known that person may have been struggling with more of a extreme response. Again, that level of distress a person experiences not being able to complete that routine is part of the distinguishing feature. Difference between the ability to tolerate change and the inability to tolerate change due to the unspoken rule. Again, oftentimes when these things are popping up, especially if the person has no logical rule for it or doesn't make sense to the rest of us in a neurotypical world, that's where oftentimes it becomes difficult for us to understand. When it's very basic and concrete, like the person says, therefore display over only, that doesn't make sense to the rest of us. We all have reasons why we would do variability, right? But it makes sense to that person. Under the atypical compulsions, also excessive questioning or reassurance seeking that exceeds developmental expectations. Is it about the contingency itself or the compulsion to do this thing, right? And so, the best way to really talk about this one is, so I have one gentleman that I work with that he asks about people when they leave. And generally he'll ask about somebody when they leave once or twice. But if a member of his family leaves the house, he's asking constantly, the entire time they're gone. The family was unable to differentiate. They said, this person just gets obsessed with people. And I said, well, I'm not sure that that's necessarily the case. When we actually took the data, and the family took the data, I was really happy that they actually took the data, but they took the data themselves. They very quickly realized when therapists run by the house, he's not as upset. When somebody else leaves the house, that's when, like when mom leaves the house to go to work, that's when he can't stop asking where mom is all day long. And no answer is sufficient until he sees the stimulus of mom enter back through that door. And things are just right. Are you catching a pattern here? A lot of just right type of stuff happening here. Repetitive statements, scripting, inability to communicate due to those obsessive thoughts that we had talked about earlier. Compulsions also embedded within or disguised by autism-related stereotypies. I have one young man who, my gosh, I have never seen OCD stereotypies the way that this young man has. 99% of his day is autism RRBs. He's just doing his thing throughout the day. But then as he's doing those things, I'm not as good as mom is, but mom will see it. And he'll be doing something, and then he'll just stop. And then she'll go, oh, he's doing a loop. And I'm like, a loop? And so in the middle of some physical stereotypy he was doing, some bodily sensation went off in his brain that now he has to do 14 million times until it's just right. And I was like, how long does that take? She's like, that can take 5 minutes to an hour. I was like, are you kidding me? She goes, and he'll do it, and you'll see him doing it, and then you see him get more frustrated about it the whole time. And so again, it's like this autism RRB that then morphs into a loop, and he can't get his brain out of it. It's torture to watch. Just so you know, he's a fun guy to be around. It breaks your heart when you see him going through one of those loops. Aggressive or self-injurious behaviors also serving an anxiety reduction function. Behaviors sometimes are disguised as attention or escape, and the story of impulsive versus compulsive. Did I tell the story of impulsive versus compulsive? Sorry, I've practiced this a couple times today. No? Okay, great. Fantastic. All right, I was telling the story out in the hall, so I was like, I got to make sure I didn't already say this thing. So that's happened before. Aggression or self-injury with the anxiety reduction function. So I had this one family who, fantastic family. But sometimes we can have too much behavioral support, all right? Sister was a behavior analyst who had trained mom to be a registered behavior technician. They had an outside behavior analyst. Everybody was a behavior analyst involved in this case. And then I walk in, and after taking some data and trying to figure out some things, I came to the house one day and I said, hey guys, I think there's some possible OCD. And every behavior analyst in the room goes, you're an idiot. And I was like, what? And they were like, no, it's not OCD. This is just an autism RRB. And I was like, why would you feel that way? And they were all making the case for, even though they couldn't see the antecedent in the environment, there had to be one, right? It had to be attention in some form or trying to escape something. And I was like, I don't know, guys. We'll have to see about this. And so we kept kind of going back and forth about this, and eventually the doctor had made a medication change in all of this that nobody really was aware of because we just weren't made aware of it. But then one day we all showed up, and the guy wasn't engaging in any target behaviors. He wasn't doing any of his usual stuff. And when we asked what had changed, about 6 weeks prior to that, the doctor had placed him on an SSRI. And his symptoms had subsided. In the absence of anybody suggesting it to the doctor, in the absence of anybody doing any behavioral intervention, an SSRI had naturally decreased the obsessive thoughts and thereby decreased the compulsions that this young man was engaging in. I didn't even have to make the case anymore, right? The doctor did it for me. The data speaks for itself, and I didn't have to say anything. Except for, I was right. I didn't say that. I said, yes, it looks like everything's great. Great job, doc. That's fantastic. But in my head, I said, I was right. So, all right, the third key distinguishing feature, context-dependent presentation. Unlike typical OCD, where symptoms are relatively consistent across time and space in that person, and again, some of that has to do with the person's awareness. If you think about people with OCD, is there anybody out there with OCD that doesn't know that they have OCD? That can't describe it and say, oh yeah, I check stuff all the time. I don't know why, right? I wash my hands 400 times a day. It must be I just am a clean freak, right? No, there's a self-awareness to OCD that makes it salient for that person, and so it's at the psychological forefront for that person. But with people with autism or intellectual disabilities where their identity might not be defined by, I'm a person with OCD, it is more context dependent and situation specific, like the tags on clothes, right? The only time the person's OCD about tearing tags of other people's clothing can happen is in the presence of other people's clothing, right? Otherwise, it can't happen. But there's other ones, and individuals that their symptoms may not make sense until we look at it in the context of what it is the person is doing. So, the case of the after-day program routine. So I was working with a gentleman who had a behavior analyst. He had had behavioral services for many years, and for the most part had been relatively stable for most of his life. He's probably in his late 20s by now. Had been relatively stable, but about 3-4 years ago, something changed in his behavior, and the next thing you know, a bunch of stuff started popping up in terms of like agitation and things like that. After a little while, they were able to get some things under control. But this one thing hung around. Since 2022, this gentleman engaged in the same typography of behavior Monday through Friday, regardless of, well, only if he had to attend day program. When he returned from day program, the moment he got home from day program, he was perfectly fine all the way home. The moment he got home, he would start getting a little amped up, start getting a little anxious, and for the next 30 minutes, he would be running around that house, engaging in high-intensity vocalizations, high-intensity physical stereotypy, jumping up and down loudly, all of those things, like the jumping up and down that knocks the nails out of the floor, that type of jumping up and down. Yeah, so you can imagine how much his group home housemates enjoyed this. They were like, oh God, here we go again, right? But what was unique was it would only happen for 30 minutes every day. That was it. So for 30 minutes every day, this thing was happening. Very high intensity, driving everybody crazy. And so we started looking at everything else going on with this young man. And this dude had tons of autism RRBs. He had stuff he was engaging in all the time, scripting and physical stereotypy and all this stuff. And so at no point in time did people consider that is there a possibility that something he's doing is contextually significant. He's, again, experiencing anxiety as he's arriving home for about 20 minutes, regardless of the unspoken rule that none of us are aware of. He's engaging in this behavior for some reason, and at some point when his brain tells him his routine is done or just right or whatever, he's able to experience relief and move on with his day just fine. Doesn't happen on weekends, doesn't happen on holidays. So the first time I presented this to the doctor, I made that similar case. And the doctor had been working with this gentleman for a few years. And so the doctor said, thank you for that information. I think it's just autism. Let's move on. And that was the end of the discussion. I was like, wait a second. I just made a behavioral case. Like, that should have made sense, right? But the doctor wasn't hearing that. What the doctor heard was a behavior analyst, master's level behavior analyst, coming in and telling her that she'd been doing her job wrong for the last 4 or 5 years. That's what she heard. Because of how I presented it, right? So the next time I saw that doctor, 3 months later, I presented it in a very different form and fashion, and I said, here's the A's and the B's and the C's and all the wonderful data that you want and everything else. Doctor, we're seeing this strange phenomenon where there's no identifiable antecedent. It almost appears as if the person is responding to a thought and acting on a compulsion. What would you suggest? Doctor added an SSRI, and 4 weeks later I walked into the group home and the male house manager says, I could kiss you. Did you see how often this happens? I was like, this is weird. Why is so many people? No, I'm just kidding. He did say that, though, which I did tell him that was weird. But I asked him why, and he said, because you got my guy back. I was like, what are you talking about? He goes, this is what he was like before everything changed in 22. This is my guy. And I sat there for an hour, and I just sat on the couch with my guy, who the last several months I'd been there, that half hour we were walking around, watching him jump and everything. We were sitting on the couch. He was telling me about Fantasia. We were looking at stickers, doing all the stuff that he likes to do when he's feeling calm and at baseline. And I thought, we did it. That was a pretty cool one. But this next one really takes the cake. This one, for me, this was probably the one that stood out the most to really try to understand how the heck this stuff comes about. Even in that illogical, fantastical, is it harm prevention? Is it something else? So, the case of the mom who couldn't talk, do laundry, or shower alone. So I got a referral for this young lady who engaged in the target behavior of physical aggression, primarily scratching. She did it when somebody was assisting her in the bathroom. She did it generally at the day program. And every now and again, she would do it to mom when people were over, or, when mom was helping her in the bathroom and everything else. And I was like, okay, all right, we'll go out and go see what's going on. I go to the day program, not much was going on, seemed kind of, escape maintained. They went to the bathroom, they asked her to get up, she went to scratch them. It was not rocket science. I was like, okay, this is cool. And then I went to the house. And for the next, I was there for about 2 hours doing a behavioral interview with mom. The entire 2 hours, her daughter sat right next to her, whining and crying, pulling her mother's face towards her, would not allow her to interact with me in any way, shape, or form. Just nothing. I was like, Mom, this is different. Is this what you're talking about? She goes, yeah, it happens with everybody. I can't talk to another human being. I can't talk on the phone. If my attention is not on her, it's bad. Scott, there's other stuff that I don't tell people about that. I was like, what other stuff you don't tell people about, if you don't mind my asking? Because I need to know. And she goes, well, she follows me to the laundry room, but people do that, right? I was like, well, what do you mean she follows you to the laundry room? Every time I do laundry, she's with me. Really, anywhere I go in the house, she's with me. Anytime. And I was like, what do you mean? She goes, all right, I haven't told anybody this because it's weird and I think it's a little embarrassing. I haven't taken a shower by myself in 20 years because my daughter won't let me. And I was like, explain, please. I need a little clarification because this is sounding a little like I got to make a phone call. And she goes, no. Here's the thing. My daughter won't allow me to take a shower by myself, meaning when I go to take a shower, I go and I get undressed and I do. She's in the bathroom and she has to be seen. It's not a sexual thing. She's not looking at me, but she has to know I'm there. And then when I get in the shower, she's there the whole time in the bathroom, right? And then when I'm done, she tells me to turn off the shower and open the door and grab the towel, step on the towel. She's controlling every aspect of my behavior, driving me crazy. And I said, Mom, this is not a common thing, just so you know. This is different. And I said, every now and again, I come across people with autism who sometimes get fixated on stuff with an abnormal intensity, right? I used to, one of the first people that I worked with carried around a white gym shoe every day and just rubbed it along his right cheek every day. That was his thing. That was his thing. And that was an abnormal intensity and focus on that thing, right? But it's like, you are the shoe. And Mom goes, what? And I go, yeah. It's like your daughter's abnormally focused on you in some way. That's interesting. Let's talk about it. And so we talked a little bit about it, and after some data and conversations and everything else, she went back to the doctor, and the doctor put her daughter on an SSRI, and that mom did not offer to kiss me, But 6 weeks later, I arrived to the house and I was doing my usual update with Mom, and I was like, hey Mom, how's everything going? And she's like, oh, you know, it's fine. And she was scratching a little day program and this and that. And about half an hour into the session, it occurred to me that her daughter, who was home, was not in the room. Nor was she next to Mom. Nor was she whining. Nor was she pulling Mom's face. I said, where's your daughter? Oh, I think she's in the she's in the living room. I was like, okay, that's different. Hey, Mom, how's laundry going? And she thought about it, and she goes, I've been doing the laundry by myself for 2 weeks. I go, how's your shower? She goes, holy shit. I go, no, how's the shower? She goes, she hasn't been up to the shower in 2 weeks. I was like, is she sitting in your bedroom? She goes, no, she's sitting in the living room. She doesn't even follow me upstairs anymore. I was like, whoa, that's cool. Huh? What do you think about that? And she goes, yeah. And so that young lady continued to just progress. And again, the doctor was like, I don't know what it is. I don't know what's going on, but I know that she responded to the medication. There was anxiety before. She engaged in behavior relief after. All of the things made sense. And that young lady was doing very well. And last I heard, she was being accepted to Misericordia. So, compulsions may also be more situation-specific and appear more behavioral than ritual-based. Lots of people with toys in vents and putting stuff in vents, right? Sometimes that's just a restricted repetitive behavior, and that's just an interesting thing. Some people, though, it's a little different. My guy that was doing the half-hour thing, 9 months into working with him, they go, Scott, we got a hoarding problem. I go, yeah, did you see his room? It's nothing but a hoarding problem. And they go, no, we found a vent. This guy had hoarded everything in front of a vent, and I don't know when, must have been on overnights, he was moving things and unscrewing it and had been hiding things for 5 to 6 years. And I was like, he's fucking brilliant. This guy's awesome. I love him. This is awesome. And I was like, no, you're never going to do that one. You're not going to get him to stop that. And they were like, we need an intervention for this. I was like, you didn't know it was going on for 6 years. I highly doubt you're going to know when it's going to happen next, right? It's a covert behavior. He's doing it when you don't know. So good luck on that one. I don't have the behavioral intervention for that. A person may also show extreme distress when unable to complete those compulsions, but struggle to explain why. The gentleman that came to my group home that required the 5-person escort and the lockdown of the school and everything else, on day 2 of his arrival to our group home, he asked his staff member for his long-sleeved gray shirt. And the staff goes, buddy, you don't have one of those. 3 head holes to the wall and a trip to the hospital later, Mom arrived with 10 shirts, long sleeve, gray. And that's pretty much what that gentleman wore for the next 4 to 5 years, right? Extreme distress when not able to just wear a shirt that he absolutely had to wear. This gentleman had a few of those type of things. You could see that he had a disproportionate response to lots of things happening. So how do we differentiate those things from RRBs? Restrictive repetitive behaviors in autism are a core diagnostic feature defined by repetitive body movements, intense fixations on specific objects, topics, strict adherence to routines, sensory processing abnormalities. These behaviors often serve to self-regulate the person to provide sensory input, range in frequency and intensity, and are mandatory. So examples, motor ones, motor actions, hand flapping, rocking, spinning. You got your repetitive verbal statements, object use, spinning things, lining up, fixating, routine, rituals, intense distress over minor changes, sensory behaviors, or special interests even, intense narrow focus on very specific things. So you can see that a lot of these things are also things that we've also been describing as things that can potentially become a OCD type or OCD-like behavior, right? And so if an individual is engaging in one of these things, and there is a significant change from baseline, again, go back to the drawing board of trying to figure out what was the change on the behalf of the person. Was there a change in the amount of distress that they are experiencing as a result of interruption or not being able to complete that thing, right? Is it the difference between, I have to do this thing, or I'm going to go through 6 people to get to that thing, right? There's a difference in the amount of distress, as well as are they able to tolerate it at other times. A lot of the other ones take really, really careful observation of the contingencies involved, because sometimes the cues that the person may be experiencing distress or anxiety can be very subtle. There's a gentleman that I work with who has a very, very subtle OCD routine that happens probably 30 times a day that nobody really picks up on. He's just sitting there at his day program, and out of nowhere, he pops up out of his seat, runs over to the nearest person, kind of looks at him in the face. As he's approaching that person, it's, and then he's doing the thing, and then once it's done, the moment I saw it, I was like, ooh, that kind of looks like a little OCD routine. I said, how often does he have to do that? Oh, 30 times a day. And I'm like, why does he have to do it? Oh, it's usually when people's faces are like scrunched up. And I'm like, okay, all right, whatever that rule is, right? Doesn't have to make sense to the rest of us. But again, is that a possible routine that person's engaging in? While restrictive repetitive behaviors are a core feature, the quality of distress when these are interrupted can indicate that comorbidity. Some research suggests that the individuals with autism and OCD show significantly higher anxiety responses to unexpected changes. It's not just a difficulty with transitions, it is the complete inability to tolerate transition and change. It's also about the anxiety-driven rigidity hypothesis that suggests OCD-related inflexibility serves a anxiety-neutralizing function, whereas ASD, preference for sameness, serves a cognitive organizational or sensory regulatory function. So is it about reducing anxiety in some way, shape, or form, or is it about organizing the world in some way, shape, or form? And I just thought this stat was important. Self-injurious behavior occurring in individuals in this study, 63% of disruption versus 18% in individuals with only the diagnosis of autism. It's a significant discrepancy. So how can we differentiate some of these? I created a nice little table to help people in terms of differentiating. If you just think about it in terms of distress, with RRBs, generally self-stimulatory, pleasurable. For OCD, anxiety-driven, distress occurs before and is temporarily relieved after. The ego-dystonicity, I was practicing that for like 3 days, still screwed it up. Ego-systonic, enjoy or value the behavior, or ego-dystonic, person is bothered by it, it's unwanted, they are showing frustration or distress, resistance to their own behavior. Have you ever seen that? Somebody who doesn't quite want to do this thing, but they have to, right? And once they do, then the anxiety is relieved. It's also about the amount of functional impairment. Autism RRBs may be extensive, but typically stable over time, provide regulation. I used to have a guy, he would kind of do this for about 20 minutes before going to day program, right? Or going to his class at day program. That was an RRB. Might have been a little OCD, didn't cause him distress. It just bothered the rest of everybody around him, right? But it was stable over time and provided regulation for him. Had nothing to do with being progressive, increasingly interfering with daily functioning, and being more time-consuming over time. It's also about that resistance. With autism, minimal internal resistance to change or transition, may resist external interruption, right? Don't like being interrupted by the rest of us. OCD, the person has an internal struggle. It is going back to that original DSM criteria, right? The person is experiencing some unwanted thing that they're not able to express to the rest of us. Cognitive components, primarily sensory for autism. With OCD, it's driven by what if? What if this thing happens? What if I don't do this? What if I can't stop this thing, right? Future thinking, all that ACT stuff. Response to interruption, frustration may occur with people with autism, but with people with OCD, it could be panic, aggression, physical aggression, self-injurious behavior, all of those type of things, property destruction. The person cannot settle until the ritual is completed. One of my favorite stories of all time was a gentleman who once, his mom locked up the iPad that he was very obsessed over in his bedroom and went to the store. And when she came back, he was in his bedroom playing his iPad. He had not gone through the door. He had instead gone through the wall, punched the hole through the wall, and went through the studs. And I thought, that's different than just knocking on the door until it opened, right? Here are some questions. I want to be able to talk a little bit about some of the other stuff, so this will be in the slides for everybody. In terms of behavior analysis, I know I didn't quite finish the thought on this slide. Ultimately, the toughest thing for us as behavior analysts that we struggle with OCD is that lack of a known environmental antecedent. Because it's a private event, because we can't see it, because we can't make sense of it all the time, it's very tough for us to distinguish or believe that it is that, right? Because even if you see that anxiety before the person engages in the behavior, you may assume something in the environment caused distress, right? Rather than taking into account, I would like to propose a twofold, sorry about that, a twofold four-term contingency, because with MOs, we generally are thinking about environmental situations that increase the reinforcing value of a stimulus, right? If you go run a mile, you want to drink water, right? Increases reinforcing value, motivating operation. But I would add to that the verbal behavior component piece, right? There's a verbal piece in there, even in nonverbal individuals, that private event piece that we're not taking into consideration. The person is experiencing an internal thing, and that, whether or not we can see it, doesn't matter. We see the result of it. We see the outcome. We see the expression that the person is experiencing as a result. So some common atypical presentations. We got the purely obsessional, predominantly mental obsessions with primarily mental covert compulsions. In nonverbal individuals, this may manifest as periods of apparent intense internal distress without any clear external trigger. The person's not able to tell you why. Mental rituals that appear as zoning out or dissociation. The person may just be sitting there counting, right? And none of us know. Subtle mental counting, reviewing, or checking, not readily observable. How many people do you work with, or can you think of over time, have been doing something and then they look back just to make sure and checking on something, even if it's not a lock. Maybe it's just that somebody's there, or something's behind them, or whatever it might be. Whatever that rule is, it doesn't have to make sense to the rest of us. Harm obsessions, in nonverbal individuals, may show extreme avoidance of situations. I would say the one that, in my experience, I've come across the most is the excessive checking that others are safe in some form or fashion, either physically making sure that that person's safe or asking, and not just being told yes. They have to physically see that that person's okay. Or self-restraining behaviors, seeking restraint from others. Limited time. Sensory motor, somatic obsessions, repetitive movements, attempting to achieve just right feelings. A person that is doing that repetitive thing over and over for sometimes a half hour until whatever it is tells them in their brain or body that it's okay to move on with their day. Just right OCD, as we've talked about throughout the presentation, this is coming up more and more. It may be just right or just not right, right? Whatever is in the environment is not right, and I need to make it right. Driven by incompleteness incompleteness or not just right feelings rather than specific feared outcomes. May present as redoing activities multiple times, symmetry and exactness compulsions, and extreme distress when things are off without a clear reason why. My favorite gentleman that I serve that has this just right stuff, as I was talking with the parents, I said, give me an example of his just right. And they said, do you see our house? And I said, yeah. And they said, we have rearranged our furniture probably 200 times. And I said, no shit. And they go, this is the exact way our house looked when he was 5. He's like in his 30s. I said, oh, wait, what do you mean? And they go, every time we move anything in the house, we can move and rearrange the whole house. When we wake up, the house is exactly the way it was when he was 5. Every single thing in the house is exactly the way it was. I was like, yeah, that's pretty rigid. Okay, cool. Okay, at least I know what the house looked like when he was 5. Do you have the same furniture? I didn't ask that, though. Excessive checking behaviors, checking compulsions in nonverbal individuals, repeatedly returning, touching specific objects set number of times, visual checking, seeking confirmation, washing and cleaning, ordering and arranging, hoarding, disorder now separate from OCD. It frequently still occurs with both conditions. The hoarding prevalence is 21% in autism and ID samples compared to 2 to 6% in general population. So the incidence of hoarding in individuals with autism and intellectual disabilities is significantly higher. Atypical features include hoarding non-functional items. How many people have you worked with over the years that hoard garbage, right? I've had tons of them. Useless garbage and gross stuff and everything else. And is it possible that that may be related to something other than just an interest in this thing? Broken objects. Aggressive or self-injurious responses to discarding. If somebody gets rid of it, what is the end result? Inability to articulate reasons and health and safety hazards as well. Reassurance seeking, but let's get to, real quick, in terms of that amount of distress that the person experiences and how it is different, 68% of individuals show aggression when prevented from completing rituals associated with atypical OCD. 68%. That's a pretty high number. That is not difficulty with transitions, right? Not being okay with change. That's something different. Self-injurious behavior at 54%. So you're going to see much higher rates of target behaviors in these, with these individuals. Diagnostic overshadowing occurs when symptoms of one condition, typically more prominent, the known one, like autism or intellectual disability, prevent recognition of co-occurring conditions. It's generally the assumption of it's just the autism, it's just the intellectual disability. The person may never figure this out, right? There's nothing different from what they were doing before. Clinicians, family members, every situation will be different, but every situation is going to have some complexity with regards to somebody having an assumption on whether it is or is not OCD, especially if you are bringing this up for the first time. Understand that resistance is going to be there because, again, you're changing things. You're suggesting something new. And oftentimes, especially, I've run into this time and time again, if a family has experienced a situation where they went to their doctor, trusted their doctor, place their loved one, especially their kid, on an antipsychotic, and they experienced side effects, and then everything went batshit crazy, and they really don't want to hear what I have to say about putting your kid on an SSRI. Unless the conversation is going to be, if we talk with your doctor, and your doctor agrees to do this thing, it's possible that they may not need the rest of the junk that they're on, right? If you believe that these antipsychotics are not for your kid and they shouldn't be on them and everything else, let's get them off them. But the way to do that is by treating the thing that they're actually suffering with. That's the only way generally to get families on board with that. How it happens, expectation bias, once a person has a diagnosis of autism, much like that doctor I worked with years ago, who I love and respect very much, he just believed it was the autism, right? People with autism don't have OCD. It's just OCD-like behavior, Scott. He was wrong. Sorry about that. Lack of adapted assessment. When I first started this topic, the first thing I did was look for an assessment. Just so you know, no good ones exist. You're going to find the Yale-Brown OCD assessment, and that one's kind of the standard for most people. Just so you know, if you try to read it, most of the families are going to look at you like you're nuts because it's mostly for verbal individuals. So we need a diagnostic criteria that is for atypical variations, for deviations from that typical understanding of it. Because what happens with diagnostic overshadowing when people just assume it's the autism, when they just assume it's the intellectual disability, people go years without actual treatment for the thing that they are struggling with, right? Would you rather have to go through side effects of antipsychotics for 5 years just to be proven right that somebody else was wrong or something along those lines? I do have a family that I've been working with that I've literally been watching a pissing match between 3 different doctors, psychiatrist, neurologist, and a movement disorder specialist, all who didn't want to take responsibility for the fact that when he was put on 2 antipsychotics at the same time, he developed akathisia, medication akathisia. And nobody wanted to take responsibility for it. And so they all said, not mine. But it's this other thing, right? Also, oftentimes we have delayed diagnosis, we have inappropriate interventions, and progressive impairment as well, which also leads to the last point I really want to make, which is the polypharmacy, right? More often than not, what you're going to find in these cases is that progression where the family or provider has gone to the doctor has generally started out with an antipsychotic or something, or a mood stabilizer. That's another common one that we see, because again, if the doctor is believing it is impulse related and the person cannot control their impulses, that's a different treatment strategy than somebody who needs something to help their brain and body feel better so they don't engage in compulsions. So generally what you see, antipsychotics, mood stabilizers first. If that is the big pattern, and they've been doing a lot with that, the other thing that you'll see is if the person is on an SSRI, they generally have been on one maybe for the last 10 years at the lowest dose possible. The doctor started it and then never did anything with it. SSRIs for OCD have to be at higher doses than they do sometimes for people with depression. And so if they're at the starting dose and there's no effect, the doctor might have to increase it, right? I would much rather have a doctor increase a medication that is less likely to cause tardive dyskinesia than anything else, right? Less likely than antipsychotics, absolutely. So it is 4 o'clock. Thank you guys so much for coming to my talk.